Hello and welcome to our first Rural Doctors Programme for 2008. I'm Jerry Gannon. Thanks for your company tonight. Our programme this evening focuses on oral health, and we'll cover topics including chronic oral infections and the use of antibiotics, the effect of diabetes on oral health, oral cancers and much, much more. We'll also visit the Geraldton Regional Aboriginal Medical Service and look into the Flying Dentist programme that delivers oral health care within the AMS clinic as part of a holistic model of care for the Midwest Aboriginal community. And later we'll hear from Dr. Kurt Gebauer from Fremantle Dermatology, who'll talk us through some dermatological conditions that can affect mouth and lips. But before we leap into the programme, I'd like to take the opportunity to make a few announcements and to let you know about some of the Rural Health West events and programmes that are coming up early in 2008. Well, firstly, a reminder that this year's annual conference and trade exhibition returns to the Intercontinental Burswood on 26 and 27 April. The Anzac Day holiday on the 25th of April may provide more freedom for families travelling to Perth for the weekend. The theme of this year's conference is Making Rural Communities Work in Boom or Bust, and will feature eminent keynote speaker, the Honourable Dr. Barry Jones. The registration brochure for this conference will be sent out later in February, and I look forward to seeing you there. There's also a couple of training courses coming up that you might be interested in. On Saturday the 23rd and Sunday the 24th of February, we have a weekend course on critical assessment and resuscitation of emergencies. That will be held here in Perth, and priority enrolment is given to locums, newly arrived OTDs and remote GPs, and the course attracts the Rural Training Grant for 2 days. On Friday the 14th of March, we'll be holding a session on frontline gynecology in Albany for GPs in the Great Southern GP Network. This course attracts both CPD points and women's health points. Now, I'm sad to announce that the programme prize draws are no more. While we'd love to be able to keep giving you weekends away, we simply can't justify the continuing expense of securing the monthly prizes. Instead, we intend to focus our efforts on making sure that the programs continue to be an excellent source of information and ongoing education by giving you access to the very best and most experienced practitioners in all areas of health, medicine, and general practice. And on that note, I'd like to introduce our panel for this evening's discussion on oral health. Our own Dr. Olga Ward will be leading the discussion. Welcome back, Olga.
Thanks, Jerry.
Did you have a nice break?
Had a lovely break, thanks.
Terrific. Dr. Mark Tennant is the Director of the Centre for Oral and Remote Oral Health and has worked in oral health research, education and service delivery in WA for over 15 years. Welcome, Mark.
Thank you.
I think
nice
that should have been rural.
A bit of rural would be good.
Sorry about that, Mark. And Dr. Ian Newnham spent 6 years as a senior lecturer in periodontics at UWA. He's now in private practice in West Perth, but continues as a part-time clinical teacher at UWA. Welcome along, Ian.
Thanks, Jerry. It's very nice to be here.
A reminder that this is an interactive program, so if you do have any questions for Olga, Mark or Ian, you can have your say at any time by giving us a call on 1-800 673 277 or 089 229 5241. So, Olga, oral health is our topic of discussion. The panel is in your capable hands.
Thank you, Jerry. And welcome.
Thank you.
Toothache's something that's very, very common as a presentation to particularly rural GPs, I think. And quite often the patient will rock up and say, oh, look, I rang the dentist and the dentist has sent me along to get a prescription for antibiotics and analgesics and they'll see me in a few weeks. Well, don't dentists write prescriptions for antibiotics and analgesics, and what else should we be doing?
Absolutely, yes. You know, dentists are able to write scripts, and to be honest with you, I think the best thing you could possibly do is get on the phone and find out why the dentist didn't actually do the script themselves. Most dentists would write their own scripts. It'd be complicated things, maybe a complex medical history or something that may have a dentist go to the local hospital and sort a script out, but you'd really expect the patient, like a normal sort of referral, to rock up with some sort of letter or something to support that. So I'd be getting on the phone and finding out what's going on there.
And if you've got a patient who presents just with a simple toothache, what sort of antibiotics should we be looking at?
Well, I think most of the infections that are dental in origin are usually quite mixed infections, and so you need something reasonably broad spectrum, like amoxicillin works very well as a first-line antibiotic. And then there are also things like metronidazole, which works really well with some of the pure anaerobe infections. And there are a lot of those in the periodontal side of things.
Yeah, okay, so patients who've got a lot of very significant, like pocketing in the gums or pyorrhea around the gums, are they the sort of patients you're looking at? Is that metronidazole and amoxicillin, or would you use just one of the agents?
If you use antibiotics in that sense as a first line, they only have a very temporary effect, because the problem is really the bacteria on the tooth surface can't be accessed by the antibiotics. So you can make the soft tissues healthier or less infected with the antibiotics, but it's only temporary. And if you don't follow it up with local treatment, it doesn't have much effect.
That's exactly right. I think the key thing here is that it's a stopgap measure.
Yeah.
Using antibiotics, whatever one you choose, amoxil, penicillin V, metronidazole, that's not the end point treatment, and these people need to find their pathway to a dentist. Clearly, you're also probably going to look at adding some sort of pain relief to that care plan, and you'd probably look towards some of the anti-inflammatory pain reliefs, the ibuprofens, those sort of things.
In one of those GP hot tips columns in one of the local medical journals, I saw that a doctor had said that she'd actually put the head of her what do you call it, electric toothbrush onto her sore tooth and just brushed it very gently for a few days, and that had taken the pain away. Is that something that, like, dentists advise, or would that have just been something that she discovered fortuitously?
No, it's very much something we'd advise. What happens is that you have a lot of infection in the pockets, and that's obviously a periodontal problem, that one, where the pocket is around the side of the tooth. If you can get in and brush it and keep it really clean, most of them settle down very well.
And do you treat the patients with mouthwash? I mean, we see quite a lot of patients, even in their early 20s, with horrible brown rotting stumps in their mouths. And whilst we might recoil in horror at somebody so young having such bad dental disease, should we be advocating brushing of rotting stumps?
I suppose there's two parts to that. I think that the first part would be absolutely yes. We're trying to set a principle up of the number one way to look after your teeth is actually very simply clean them. There's no smartness in this. And I think the other part to the answer is often with those 20-something group, they may well be suffering from some problems with their wisdom teeth and the gum sort of growing over their wisdom teeth and things. And in that case, breaking up the debris and the plaque that's around those teeth will certainly reduce their pain problems.
Now, that's something that GP's also seen is the sort of semi-erupted wisdom tooth with a little flap of gum over the top. Is there anything in particular that the GP can do for that?
With those, I think number one is just brushing. If you can get in there and brush it really well, you can get quite a lot of healing. The other thing, as we've just been talking about, is antiseptics. If you can work an antiseptic into that area, even if you dip the brush in the antiseptic, such as Savicol or one of the chlorhexidine-based ones, even the gels are quite good, and work that in underneath the edge of the gum, that will help kill a lot of the bacteria there.
Or even taking a blunt-ended needle on a 10mm syringe and just washing around the area and irrigating around it. That can be very effective. In fact, a very effective methodology, and it would be what probably most of us would do as a first line as a clinician. So.
Now, and you said mouthwash, and most of us are familiar with chlorhexidine-based mouthwashes, and then you said and gel. Is there a gel?
Yes, you can get chlorhexidine as a solution, just a liquid, but it also comes as a 2% gel. And that's quite good for working into difficult areas because you just work it into that site. And it just takes a bit longer to wash out, so. The longer it can stay there, the better.
Yeah. Now, occasionally the patient will rock up to the GP and what they've actually got is a broken tooth or a dislodged filling or partially dislodged filling. So they've got horrible throbbing, shooting pain, and they're just desperate for you to knock them out with pethidine or something. What kind of measures can a GP take in those circumstances, given that often the patient can't access a dentist for days or weeks?
I suppose my immediate, you need to think through what's causing the pain, and often that pain will be some sort of inflammatory condition in the pulp or around the apex of the tooth, and therefore you'd immediately start thinking down through some of the anti-inflammatory pathway that we talked about earlier. The idea of plugging up the hole, that's probably not even a frontline thing that in that situation where you've got someone coming in acute pain is probably not a priority. I'd be looking to those anti-inflammatories. You can run the risk of plugging up the hole of actually exacerbating the problem because you're
plugging the infection behind it.
Absolutely, and there's no escape for the pus basically from the pulp of the tooth. On the other side of that coin, if they've come with just the problem of the filling has fallen out, then there are certainly some very simple materials that a remote or health practitioner of any sort can actually use in those cases. And the dental legislation in Western Australia actually allows for that to happen, for doctors to actually do acts of dentistry. So you laugh.
It's distinct from acts of God.
Yeah, you laugh, but actually in some jurisdictions, brushing your teeth is an act of dentistry, and you're not actually allowed to do it unless you're a qualified dentist. So there are some bizarre situations. But docs in the bush are actually exempted from the dental legislation in some clauses, and they can do that.
How would they find out about learning to bricklay a tooth?
I think the best thing would be to make contact. Firstly, my primary contact direction for all rural GPs is to look to your local dental practitioners. Take them out for a beer on a Friday night and make friends, you know. But the secondary contacts are certainly through centres like the Centre for Rural and Remote Oral Health, and the contacts are obviously available through the group here and things. So there's always people around who will help through that journey, yes.
Super. Now, patients who do come in with broken teeth or broken fillings will often have a really sharp edge. And supposing that we don't have any dental spac filler and we can't actually fill in the hole, do you have any kind of simple practical tips for taking the sharp edge away, again, until the patient can get to the dentist?
I think one of the simplest things is if you've got a piece of sandpaper, and that can be anything from an emery board or anything that nearly everyone's got access to. And if you just file down that sharp edge, it doesn't have to be fancy, just take the sharpness off the edge. That's not going to affect what the dentist does later. And if that makes it more comfortable, that's fine.
Super.
But don't get the pliers out.
No.
Stick with the emery board.
Yeah.
Very unusual. What about the patients who have actually seen the dentist and they've had a tooth extracted with the pliers or whatever archaic instruments you use instead of pliers, and then they come in a day or two later after the dentist has left town and moved on to the next town, and they've got socket pain?
So, okay. If they've got pain from the socket, right, there's a number of things that are happening there. Firstly, the blood clot that forms in the socket after the tooth's extracted would normally stay there, but if it comes out, and that can happen fairly easily, then the bony wall is left exposed and it can often become inflamed and infected. If it's infected, then obviously antibiotics are a good way to just cool it down for a while. And then if it's inflamed, then it's the anti-inflammatories that we come back to again. So
now, I've been used to packing dry sockets with a bit of Tink Benzone gauze. How much use is that, or is that a very outdated thing to do?
That still helps. That still
What
helps.
are you actually doing when you put Tink Benzone gauze and put it down a socket?
Just trying to kill the bugs.
Okay, so it's a bug killing thing. We're not bridging skin or anything.
No, there's no special.
No, nothing special, but it helps. If it makes it more comfortable, food often packs into these sockets, and that can be pretty uncomfortable. So
irrigating
anything
can also be helpful,
that washes
or
it and keeps it clean is useful, or stops food getting caught in them is fine.
I guess our other common situation is the patient who's walked into a fist and lost a tooth.
Yeah.
Now, sometimes we're lucky and they come straight in clutching the tooth. What could we do then?
I think the immediate, the international literature shows the immediate thing is get the tooth back in the socket. The faster the tooth goes back in the socket, the greater the probability that it will rebind to the alveolar process and be a tooth again. The interim in that is if a person rings you and says they've knocked a tooth out, it's milk, plain old, and I'm not arguing about skim or whole cream, milk, and put it in milk and then come along and replant that tooth.
How do you get it to stay in? Because it's usually a front tooth.
Yeah, it is normally a front tooth, yeah.
How do you get it to stay in once it's in?
You can use all sorts of materials. I know this sounds horrible when you think about it, but alfoil, wrap alfoil and make a pack around it to hold it in. Yeah, it sounds shocking, but that's a really effective way of holding it in. The key element here is that on the root of the tooth that's knocked out, there's actually still a living cellular component. So the idea of the nurse grabbing it, giving it a good scrub before you put it back is just not the process. Make sure you just wash it gently in milk or saline or
the grass
Hanks
off,
or get the grass off
the bits of other people's
aim
knuckles.
to get it back. Aim to get it back.
Good. If there's a fractured jaw associated with one of those injuries, do you still reimplant the tooth?
It gets a bit more complicated. It depends whether the tooth is lost on the fracture line, which is probably what's going to happen. And in that case, you wouldn't go to be replanting that tooth immediately. With jaw fractures, often it's hard to actually pick whether a person has a jaw fracture, and I often get asked the question, how can we tell?
Yeah.
And the primary thing people complain of is that their bite isn't like their bite is normally.
Yeah.
And if a person is saying that to you, then, lights should be going on about a jaw fracture. Issues about sort of vertical tears in their gingiva and alveolar mucosa, that's another sentinel sign for a jaw fracture. And we're really lucky in WA in that you ring Royal Perth Hospital Exchange and there's always an oral surgeon on call through the hospital, and they will help you through the diagnostic and treatment pathway 24 hours a day.
Super, that's great. We might leave it there and go to our segment now.
Can I just ask you a quick question about the use of mouthwashes, those ones that are advertised on television? They come in about 14 different flavours and colours and they shoot you out of a cannon. Do they work in terms of general oral hygiene?
I think the answer is, do they have any impact on the bacteria? The answer is yes, it can be measured. Yes, it does happen. But is it going to get the tissues healthy? And the answer is no. Because the plaque is too well organised, the bacteria don't let the antiseptics or antibiotics into the plaque itself.
Something they don't tell you on the advertising, is it?
Well,
all right, thanks guys. Well, Indigenous Australians carry a disproportionate burden of disease in just about every area of health. So it's not surprising that this disparity is evident in the area of oral health. Tonight we look at how some Aboriginal communities have teamed up with the Centre for Rural and Remote Oral Health to help provide effective, timely and accessible dental care to alleviate some of that burden of disease.
Aboriginal people have a terrible track record when it comes to looking after their health, and in particular their oral health. Majority of our people tend to come to us when their oral health needs are so bad they need huge concentrations of treatment to actually get their oral health back.
Like probably many health conditions, we find that it follows poor socioeconomic status. So that's a big predictor of poor oral health. But Indigenous people suffer not only with their poor socioeconomic status, but again they're burdened through being Indigenous, and their oral health is twice as bad in some ways you could look at, or doubly as affected.
Their like teeth are rotten, a lot of holes, missing teeth, some where little stumps are just left and black teeth, and that, yeah, mainly the most problems. And gum problem too, gum disease and all that.
It has a huge impact on their personal presence when they're actually meeting people, greeting people, and mixing with people in the broader community. A lot of people don't smile because they're very conscious of not having any teeth. People trying to eat an apple and they got no teeth. Well, it's just not going to happen. People's ability to process meat, it's not really going to happen. So what they're actually doing is more or less ripping the meat with their teeth and just swallowing it.
Some people just won't have a proper meal because of their teeth and whatever gets into the holes or whatever just gives them a lot of pain and suffering.
Okay. Really sore around there.
Yeah, it is.
Currently there are dental clinics within 6 Aboriginal medical services around Western Australia. They're in Carnarvon and Kalgoorlie, and Roebourne, Walloona, Geraldton, and the newest one that's just opened is in Warburton Health Service. And these clinics really came about through doctors actually identifying a need. They're finding they're being burdened, they're overburdened with dental problems, and thought, what can we do?
Well, before the clinics were set up, I suppose people would either just go to their doctor for antibiotics and put up with it, or they'd travel really far. Like in Walloona, people would travel to Kalgoorlie or Meekatharra to see the dentist. In some of the remote areas, there's a bit of bush dentistry done. Like there's some people that will actually take out teeth.
We have the clinics on a fly-in basis where they run for about a week in each location. And so on average, it's a bit under once a month in each clinic.
Every Monday we'll fly out, and then every Friday we'll fly home for the weekend. And every now and again we'll be back in the office to do procedure manuals and admin work, but we're pretty much out all the time. But generally we're not here often enough to provide comprehensive care for them, so we're trying to move away from saying we're taking care of their mouths completely and more get them introduced to it. We'll do some of the work and try to move them into the mainstream services like the government dental service as well. But in other clinics like Warburton or Walloona, where we're the only dental clinic, then it's really quite useful for them to have our service there. There's no dentist in the surrounding area.
We've had some real horror stories in relation to oral health. We've had people fronting up at the front counter informing us that I've taken X number of Panadols, or I've drank a bottle of whiskey. And it's really sad that in this day and age that you're still seeing that level of pain being experienced by Aboriginal people around oral health. Dental services, like a number of private services that are out there in the community, they're so out of reach for Aboriginal people. Private health insurance is not something that Aboriginal people actively invest in. Most of our clients are on some sort of Centrelink payment, some sort of work for the dole program like CDEP. So there's not a lot of dollars left in the purse after they pay for the essential living stuff. So $20 to them, for example, is like $100 to some of us who work. So you start talking about you have to pay to access service, it starts to put up some barriers to people actually accessing. So what we are able to do is to target those people who are on Centrelink payments, who are on either a pension, who are a part of a CDP work for the dole type program, and provide them good quality dental care at no cost.
Having a clinic here is better access for all. And it's just knowing that the dentist is here, they'll come. And being an Aboriginal organisation, be more comfortable for them too as well. And know the friendly faces at the front. And we've got like transport for them, so if they need transport we pick them up and bring them and take them home.
The dental clinics is integrated into the whole of the AMS here, and it really does give us an advantage over many of just your normal private dental clinics that are around, both here in Geraldton and all over the place, all over WA, purely because it gives us that, because dentistry itself is not is not a separate entity. Your mouth is not separate from your body. It's all part of the same system. And things that present in your mouth can affect your general health, and your general health can in turn affect your oral health. And that's why it's very important for us to be in contact and with the doctors and also nurses and whatnot, so that patients can get basically treatment for their whole body, a holistic approach, all the systems at once.
Basically, any patient that goes in and sees one of our, for example, they don't have to see the dentist, they actually could see the doctor, they actually could see the health worker, and those two other providers could actually then refer the patient onto the dental program. And within our service, it's actually quite a simple process. It's just a matter of a doctor putting in some notes in the patient's file, the health worker then being informed, hey, I've seen a patient who definitely needs to be a part of your oral health program or the next visit by the dentist, and that patient's name is then added to the list. Then we do the necessary contacts. So in a sense, it creates a one-stop shop.
It's both ways. We get referrals through from the doctors occasionally, but also we refer them to have tests with the doctors. I think the most prominent one with this is diabetes. Patients that present with very severe gum disease, often that's a first indicator of diabetes, so we send them off to get that treated and seen to.
What we will get you to do is go get your sugar tested, if that's okay. Because when you've got infections like this, like such bad gum disease and heredity, it's most likely that you have diabetes.
Yeah, because a couple of years ago they found a bit of traces of sugar in my blood.
Oh, yeah.
Yeah, but not a lot, but I might have got.
We can go in and relieve people's acute symptoms, and that's very valuable, but it's the long-term change in behaviours and oral health outcomes that we're looking for as well, and to working alongside and working with Aboriginal people in the actual dental clinic is a key to the success as well. And so we run, every clinic involves some sort of training or education and development for health workers in oral health, either in oral health promotion and awareness of oral health issues, but also there's a program in dental assisting that we welcome people to participate in, and we provide training.
We don't get to see the majority of our patients until they get a toothache. And part of the role of people like Leanne is to break down that barrier by doing a lot of positive health promotion stuff, by encouraging our people to get regular dental checkups, to come and see us on a more regular basis, and not leave it till the only option the dentist has is then to actually pull the tooth out. And, just work with people around doing that.
I take diagrams around and show them of sort of tooth problems they can have, gum problems and all that, and what it can cause, what sort of, how they can benefit from it, like, because diabetic people, their teeth will go quick, if they don't look after their teeth and that. And I just go out and encourage them to like brush their teeth, make sure they have regular teeth checkups and all that. So and make sure that the kids start young to brush their teeth so they don't have any problems as they grow up too. It's starting to sink into people's head that they need to come and get their teeth checked regular.
I think even at the individual level, we shouldn't underestimate the effect that we can have, and for anyone suffering dental disease, if we can eliminate that problem from their daily lives, then it will make such a difference not only to that person and how they interact with the rest of the community, but to even the community, on a wider level as well. Because if you're suffering daily with toothache or problems in oral health, it'll affect what you eat, how you feel, how you interact with people, and really that is needless suffering that we can and should be doing something about.
It's just like a sign of madness where you have a lot of focus on other chronic disease and other diseases being classified under chronic disease headings, but oral health never is. It's sort of like, that's oral health. But oral health in the Aboriginal content and in Aboriginal health, it is chronic disease. It has a huge impact on the health status of Aboriginal people. And the sooner we are able to do something about it and acknowledge that, the better off we're going to be, and the better services that we're actually going to be able to provide Aboriginal people, and that complete service, rather than just look after all the other chronic disease conditions and forget about oral health, but actually include oral health under chronic disease, particularly when it comes to Aboriginal people.
And our thanks to everyone at Graham's and Crow for taking the time to speak with us. And Kate Dyson from Crow asked us to acknowledge the work and effort of 2 GPs that, in her words, were instrumental in setting up the oral health clinics. That's Dr. David Atkinson from Broome and Dr. Marissa Gillies from Geraldton. Now, if you'd like any more information about when and where the dental clinics take place, you can visit the Centre for Rural and Remote Oral Health website at crow.uwa.edu.au, and information will also be posted on the Rural Health West website. Now, before we return to our studio discussion, a reminder to you that you may call us at any time if you have any questions or comments for our panel. The number is 1-800-673-277 or 089-229-5241. Mark, one of your people, Kate Burgess, who featured in that video, just a week in the job apparently?
Absolutely. She's one of the new graduates from last year's group of dental students, and very passionate about Indigenous health, and has joined our team as one of the flying dentists, and I think she's enjoyed her first week. A bit of a shock to have a television interview in the midst of it, but it was good.
She performed very well. Now, we were talking about Listerine before we went to that segment. You wanted to say something else about that?
Yes, obviously with these, a number of these mouth rinses, let's not pick on a particular brand, but a number of these mouth rinses actually have a significant alcohol proportion in them. And clearly with some population groups and in some locations, for example prison, there's some complications in the use of those mouth rinses. So just be aware it's not as simple as just recommending a mouth rinse in some groups.
It was fabulous to see the excellent access that Indigenous people can now have to dental care, at least in some of the Aboriginal medical services, and we're delighted that that's coming through. What's happening with the other dental service, public dental services that we see, particularly patients who just say, "Oh, doctor, I've come to see you because you'll bill me in the dentist. I can't afford to see the dentist." So public patients.
Yeah, it's a really tricky thing in Western Australia and a number of jurisdictions in Australia. No one actually gets free dental care except people kids through the school dental service.
Yeah.
So it's income dependent. So the government sector dental care in Western Australia, people still have to make a contribution towards their dental care. And for some people in some places that's prohibitive, and it's a really tough road. So there is a contribution that needs to be made towards paying for dental care. Obviously, if people have a hugely swollen face or something like that, those fees are often waived to get people through and things. It's a reasonable thing, but it is different to an ED.
Yep. During the break, we also had a call from Graham Rollins, and he was asking about a hot topic in the media at the moment, and that is Fosamax, and particularly Fosamax bisphosphonates, and jaw pain or mandibular pain and dental consequences. Would either of you like to comment on that?
Well, I think with the bisphosphonates, it's very interesting at this stage because we're still in the early phases of knowing really the significance of it. But certainly if you end up having to extract a tooth, the question is how far does the death or necrosis of bone occur around it? And it seems that the American Academy of Periodontology came out with the figures where they said if the patients have been on intravenous bisphosphonates, then that was certainly a major risk factor to get massive necrosis of the jaw.
You would think that it would actually improve the bone healing, wouldn't you?
No, because it's the osteoclasts which are inhibited by the Fosamax.
Mm-hmm.
And so therefore the bone's first step in healing is to remove the damaged bone, and that's the step that can't occur.
Oh.
So you inhibit the osteoclasts, which is very good if you've got osteoporosis and you're trying to stop the loss of calcium, because then the osteoclasts can't remove the calcium from the bone. But if you've got an open wound, such as following an extraction or a fractured jaw or something like that, the first step has to be that healing phase.
So would you advise us to take our patients off bisphosphonates for a week, a month or a year before they have to have major dental work?
It seems that the Fosamax stays in the bone and stays active for maybe 10 years.
Oh.
It's a very complicated story.
Yeah.
And, you know, in terms of the high dose stuff, clearly then have some interaction with a dental practitioner if you're going down that journey pathway for patients.
Yeah.
For the lower doses, the oral doses, we still don't know everything because there seem to be some cases occurring where you have a lot of massive necrosis, but not always. So how do we draw the line as to which ones are which? I don't think we really know just yet.
Yeah. Oral health also seems to impact quite a lot on our patients who are being treated for other things or who are suffering from other conditions. And I'm thinking particularly about patients who are undergoing radiotherapy or chemotherapy or who have some systemic diseases. Could either or both of you comment on, say, start with the patients who are terminally ill?
Okay, let's maybe just talk about radiotherapy to the head and neck to start off with. One of the problems there is that it damages the salivary glands and they can end up very, very dry. Now, there are a few things around like biotine or biotini, whichever way you like to pronounce it. They can help the saliva.
That's a gel?
But, well, it comes as a toothpaste, a mouthwash and as a chewing gum.
Yep.
If they've got some saliva, that can help. But some of the patients following radiotherapy are absolutely bone dry and there's almost nothing except water which helps, and then it's only for a few moments. So there are some real problems there.
And your teeth are only present in their elemental form because of the balance of the ions between the saliva and the tooth surface. So as soon as you upset that balance, it can be a very rapid process of destruction for teeth. So in the journey path of radiotherapy or anything where you even a whole suite of drugs causes drying of the mouth, there needs to be some aggressive monitoring of that, and certainly I would recommend anyone going down that path has an interaction with a dental practitioner. You can lose an entire set of teeth in 6, 8, 10 weeks on that sort of journey path if you're not careful.
Okay, so that would be the radiotherapy patients where you may have to do proactive extractions of perfectly good teeth before they have the radiotherapy? Is that something that's done?
Depends a little bit. Sometimes with radiotherapy, I mean, the patient's life is more important than the teeth. So the first step is obviously the medical side of it.
Yeah.
But then at the same time, you just have to consider the dental side because they still have to eat at the end of the day.
Yeah.
So, and have to be comfortable.
And I guess I'm also thinking about the patients with Sjögren's or scleroderma who also have an extremely dry mouth. Yep. Is that something where the GP can get involved proactively?
Yeah, I think so. The biggest dilemma there is how to keep them sort of functioning well. There are a number of other things you can do apart from just the keeping everything moist. One of the problems is that you get a lot of decay around the necks of the teeth when you have a dry mouth.
Yeah.
And fluoride is a major help for that. And there's another product out now which is coming from Melbourne which is called tooth mousse.
Yeah.
And the whole aim of that is to push calcium and phosphate ions back into the tooth.
No, I've seen that. That's casein and
that's right. Yes, it's
and calcium basically.
Milk product. And they had a little trick. They pushed the pH up and suddenly it worked. So they seem to have got it right. So that's another useful thing.
And that is not something you have to brush with? Is that something that's just applied to the teeth?
Yep. You just put it on your finger, rub it around.
And all it's doing is just tipping that balance back towards pushing the calcium back towards the tooth. So it's a really smart little piece of Australian invention. So,
and that would be something, I guess, that the patients would then have to do on an ongoing basis.
If they're in that situation, the answer is yes. Yep. Yeah, that's long term. And that can be bought from dentists because I think they're still marketing just through dentists, aren't they?
It's still just through dentists.
Yeah.
And it's called tooth mousse.
Tooth mousse, yes. There's cows all over it.
What about some of the other conditions that we see, such as the patients who have terrible gum overgrowth when they're on epilepsy medications or even during pregnancy?
Mm-hmm. Okay, one of the things that happens is if you think about epilepsy, you don't get overgrowth of tissues in other parts of the body where it's basically sterile. So in the mouth you have this problem where you have plaque on the tooth plus the drugs. And certainly Dilantin's famous for it, where you get this overgrowth of the tissue. The first and most important part of all treatment there is to get the cleaning really, really effective. And fortunately now we have electric toothbrushes which make it a lot easier, because you just have to aim the brush down onto the gum line, hold it there and let it really wriggle its way in between the tooth and the gum, and that's much more effective than virtually anything else.
Okay. Would you recommend this for, say, children who are being started on epilepsy medication?
Sure, absolutely. Yep.
Do you know of any other medications that particularly cause gum overgrowth?
Ooh, there's a whole list of them. But I think the thing there is to monitor the tissues. If you see that the tissues are starting to swell, then you've got to really get in and keep them clean. There are a lot of other things dentists can do later to reduce the tissue if we need to. But I think really effective cleaning is the most important step.
And would that be the same kind of treatment for the patients who are pregnant and who have gum overgrowth?
It's exactly that. In fact, we all have known for a long, long time, during pregnancy the hormone levels go up, especially during the second and third trimesters. That's estrogen and progesterone in particular. And those two hormones specifically feed some of the bacteria that cause gingivitis. And so again, you come back to the same story. If you can keep them clean, you get rid of the bacteria and then the tissues settle down very nicely. But it takes a bit of effort, and the first step is, of course, when you start brushing, everything bleeds. It makes an awful mess. So there's a hurdle to jump at the beginning.
That's when the patients stop brushing because they're frightened.
Yeah.
So we just need to encourage them through that.
You've just got to get over that first hurdle, put up with the bleeding to start off with, and then it will settle down.
One of the other things that patients occasionally consult the godlike GP about is dentures. Now, dentures are something I know very, very little about. And some of the patients, they have dentures or bridge work or, I'm going to have a tooth implant, doctor. Could you comment on any specific problems that we might see?
I think the immediate thing you probably would see in general practice is people coming with dentures that are loose and not effective any longer. And there is no stuff you can buy at the chemist that will glue them back in a sustainable way. The reality is dentures actually need replacing more often than people think. These days...
Is that because they're resorbing bone?
Exactly, it's a dynamic environment, and you're building a piece of plastic to fit a dynamic environment. It's a hope journey, isn't it, really? And so we talk, the 3 to 5 years at least for relining, readapting to the different environment is a denture pathway. Clearly the implant journey is and that modern technology is astonishing. Implants, some of the, even the original work shows that you're talking, 95+% success over 10+ years for osseointegrated implants. So I think as the current younger generation go through the loss of teeth, we will see many thousands of more implants around, and it's going to complicate our old age care and things, all sorts of problems to come.
Yeah. Well, that's all we have time for. Thank you very much for joining us tonight.
Perhaps our GPs should recommend to their patients to read that Pam Ayres poem, I Wish I'd Looked After My Teeth. Thanks, gentlemen. Our final segment of the programme tonight looks at a range of dermatological conditions that are also part of the oral health picture. We caught up with a dermatologist and clinical lecturer, Dr. Kurt Gebauer, at his practice in Fremantle, and he gave us the lowdown on 6 important dermatological conditions of the mouth.
Perioral dermatitis is a strange condition. Firstly, the name's wrong. So perioral implies that it's around mouths, but what often fools doctors is it can be around the nose, and it can be around the eye, and it can be all of the above. Most people's concept of dermatitis is something that's itchy and uncomfortable, and this isn't. You have normal lips, and then there's almost like a white band of normal skin, and then there's this rash comes up. It's a very characteristic pattern which spares what's called the vermilion, that tissue just around the lips. And these people come in and just say basically it's ugly. You know, they don't complain about itching or burning or stinging or any sensations. They say, I've got this thing in my face, it's been there for 6 months plus and it's ugly. And they're nearly always young women. So young women to me is 20 to 40, they're young women. So that leads us to wonder, well, why does that happen? Why is it this group? It's very simply, in the few children that we see, they've all been using topical steroid creams. So they've got something out of the cupboard or they've had something prescribed. And normally the topical steroid creams that are responsible for causing this are the Alicon Novazone family. I've done it a number of times with Advantan. And things that are clearly inappropriate for the face. So they had some Diprazone or Betnovate or something like that from a rash on their ankle or that Dad used, and say, well, rub some of this on and you'll be right. So what you see is you see the lumps and bumps, they flush, and after a while they get little pus heads, little pimples. But in the women, if you sit down and talk to them, they've often used Clinique, Nutrimetics, oil of Ulan, oil of Olay, and Nivea. There seems to be something particular about those brands that represented very highly in this group. So they're the things that trigger it off. What do you do about it? Well, you can get rid of it with cream. As a rule, I don't recommend cream because it takes forever and compliance is a problem. But certainly something like Elidil cream applied twice daily for 4 weeks, 6 weeks will help. Eriacne, any of the antibiotic gels might work. I don't bother, I go straight for oral treatment, except you get the odd girl who'll say, I don't want to take anything by mouth. That's their decision. But if you want to get them better, any of the tetracyclines, any of the erythromycin. So if you've got someone who's allergic to tetracycline or a child, or someone who's pregnant, there are reasons why we wouldn't use that drug. You can get away with erythromycin, or even if you need to, some Bactrim. And tricks of the trade is tell all the patients nothing's going to happen for 2 weeks. If you do get sensation, itching, burning, stinging, all that goes, the flushing starts to stop happening and the colour just fades and the whole thing goes smooth, and they usually need about a month of treatment. What do we do with lip lickers? Because it's a habit. You've been boating or you've been riding your bike or you had a bit of sun and you got a bit dry and you start licking. And we all know that if you lick, you make your lips wet and then they dry out. So then you lick them again and it gets into a cycle. So most of us can stop ourselves, but some people can't, and certainly some of the children can't. So what do? You can't just say, stop doing it. It doesn't work telling people to stop a habit. You have to give them something else to do. And one of the things is they all go to the chemist, because these are things they usually don't ask the doctor about. They go to the chemist and they sell them chapstick or something, which is one of those sort of Vaseline sticks which they push. So it's like using a bulldozer on damaged skin. So the actual rubbing of the medication or the cream given to them by the pharmacist makes the whole thing worse. But that just puts a lining of moisture on their skin, but they still lick through that. So it's just a simple thing. My favourite is I usually get them to get the chemist to make up something, it's called compounding, put it in emulsifying ointment, which isn't as greasy as Vaseline, and I get the chemist to put 2% iodine in it. So it's the old traditional stuff that Mum tried to do with us. You know, if you bite your nails, it tastes bitter, it's horrible. You know, it's healthy, it's in fish, that sort of stuff. They stick it in salt iodine, so it's not toxic. And you probably wouldn't sit down and eat the jar with a spoon, but you know, something that they can get, it's on the PBS, it's cheap. Most chemists should be able to make it, and Johnny or Sarah or whoever needs to have someone apply it 5, 10, 15, 20 times a day. And every time they lick, they get that horrible taste, which then mentally reminds them that their habit, and it undoes the cycle, and usually that settles down quite nicely. You know, all of us have this idea of skin being sort of bricks stuck together, and our tongue's made of the same thing. But what happens in geographic tongue is that whole big chunks of skin cells or tongue cells fall off. So when you look at the image, you'll see you'll have normal mucosa and there's holes in it. So it looks a bit like an atlas of the world where you've got the land bits and you've got the sea bits. And if you look at it day after day after day, the pattern changes and moves around. And it's classically the tongue. And that's why it's called geographic tongue. Nobody knows why it happens. It's probably, from my point of view, it's a form of psoriasis, because a number of them do have a bit of psoriasis elsewhere. Most of them entirely asymptomatic. It doesn't bother them. They don't feel it, they don't know it's there, but one day they're cleaning their teeth or sticking their tongue out at a policeman or something, and all of a sudden they look at it and they go, hang on, and then they go rushing off to the doctor. And if they're very symptomatic, some of them will say, look, I can't eat chilies, I can't drink hot fluids and things. We will often use one of the steroid inhalers, so the ones that we use for asthma. My favourite's Qvar, it's no better or worse than any of the others. And we do them stick their tongue out and get the inhaler and just fire onto the mucosa, because all the little steroid particles get stuck into the mucosa, they stay there, and it stops the inflammation, because at the basis of it there is inflammation. The only problem with the inhaler is that if they're using it too often or they're prone to thrush, if they get a lot worse, so I always warn my patients, so, if it goes terrible and you get a really red or a sore mouth or you get a lot worse, then you've probably got thrush and we need to treat that. But generally they get better, usually pretty quickly. But most of them, asymptomatic, doesn't bug them. But it's just one of those things to say, it's another one of those weird things that happen in medicine. Really, don't worry about it, it'll be fine. And one day it just goes, disappears. Black hairy tongue is nearly always smokers, but sometimes they're white. So these are people where, again, it's the tongue, but instead of holes like Geographic, they have extra growth of skin cells on their tongue. And the reason behind that is because nicotine actually makes the skin lining of your mouth thicker. These people are only smokers. You never see it in anyone else, and they will complain of, it looks yuck. Often it smells like the bad one, which is all green and black. That person will complain of halitosis, complain of loss of taste for food, and often they'll say, look, I just smell like a bottom of Budgie's cage in the morning. It's just, my mouth is dry and it's horrible. And I get people who scrub their tongue with a toothbrush. I've had people who've actually used a knife, stick their tongue out and try to sort of grate all this stuff off. Ultimately, they must stop smoking. It's just another reason for them to stop smoking. But that's not that easy for them to do, so what do you do in the meantime? Again, non-medical. Tell them to go down to the markets, get themselves a fresh pineapple. Why? Because fresh pineapple has an enzyme in it called trypsin, and trypsin dissolves the scale in their mouth. So they get themselves a pineapple, it's cheap, it's healthy, they chop it into little cubes, and these people suck a strepsil-sized lozenge of pineapple. And it's not a chew, swallow thing, it's like you do with Tic Tacs or Chewies. It sits in your mouth and you work it around, you play with that, and what it does is it's got the fibre in it to actually grind the scale off, and the enzyme in the sap dissolves the scale and lifts it off. But ultimately it'll go on and on and on until they stop smoking. Leukoplakia, another one of those wonderful medical terms, a leuko white plakia patch. So these are the people who come in nearly always bottom lip, frequently have been smokers, are smokers. So when they used to smoke, that's where the fag went, and it's on one side or the other. And what these are, it's the equivalent of a solar keratosis on the lip. So basically there is unstable, dysregulated growth of the bottom skin layers of the lip, so the area is hyperplastic, it's growing too quickly. So why is that one important? Because it's one of the very few skin conditions that you can say this is pre-cancerous. There's not many things we can point out and say you are going to have a problem with this if you don't do anything about it. Don't muck around with it. Make sure you treat it or get it treated, because these people will, in all likelihood in time, get an invasive squamous cell cancer of the lip. So things that they complain about, they'll say it cracks, it splits, it peels, they'll sometimes be sitting there and pulling little bits of skin off as it flakes, because it is just hyperplastic skin. Simplest thing, any doctor can do this, treat it with cryotherapy. Liquid nitrogen works brilliantly on these. So there's liquid nitrogen with either cotton wool bud, if you've got a cotton wool bud, or if you've got a cryoc gun, a spraying with no trouble at all. You just freeze it, and you freeze it like you would a keratosis anywhere else. And like one on an ear or a nose, the same level of aggression, the same sort of enthusiasm as you would someone's nose. And what happens is they get a little burn. I tell them it's like a little pizza burn, or they bit into a hot pasty, gets a bit puffy. As a rule, they don't blister. They usually don't have that much trouble at all. It's a bit sore for a day or two. Then they need to moisturise. We like QV lip balm for the reasons I said earlier, because it rubs on rather than destroys tissue. And the moisturiser is just to stop it, because it goes through a phase where it gets cracked, and it's to stop it from cracking and splitting, and the whole thing just heals up. Advise them that they'll get it back again, because all you've done is remove the most unstable skin. They still have abnormal skin, and in time, 3 years, 5 years, 7 years, they'll get little bits of leukoplakia back. If they wanted to, you can get them to apply topical retinoid cream Stevia A, Retrieve, that sort of group. These are the things that are sold for acne on prescription. And a tube of Stevia A, which will last them a year, it's cost them about $30, and they rub a very small bit on every night, just routinely. That's all it takes. And they just have to go bang, bang, every night just before they go to bed. And what vitamin A will do is reverse sun damage. So it's the only chemical that's ever been shown in proper scientific studies to improve the quality of the skin. So it reverses a lot of the damage that the environment cigarette smoking has caused, and that will keep them out of our hands. Scrotal tongue is really too much tongue. But basically, when you look at these people, and these are, again, totally normal people, they're usually youngsters, so people 15 to 25. And again, for some reason, they've just looked in the mirror and they have a tongue that looks like a scrotum, in that there's all these hills and valleys, and you can see that on the photos. So they have this higgledy-piggledy, wrinkly sort of built-up tongue, and it's entirely normal, and it doesn't bother them one bit. Why is it there? We have no idea. It's just an abnormality of normal tongue function. And it's just one of those things that often you just have to reassure them, look, it's normal, people have it, we can't do anything about it. You know, if they're really sort of uptight or excited about the whole thing, you know, try the pineapple, try the difflam C, because it gives them something to do. But usually they just settle down after a while and just come to terms with the fact that they've got a wrinkly tongue, like, so what?
Dr. Kurt Gebauer there from Fremantle Dermatology. Do any of you gents want to pick up on scrotal tongue? It's a funny name for what is a sort of what he says is a sort of a normal condition. Any take-home messages for our doctors before we leave?
I think maybe if you have acute dental pain, antibiotics are a good way to just relieve the initial problem, and amoxicillin or flagyl or together if it's severe enough.
Mark, your take-home
I
message?
suppose mine would be make connections. Dentists are often isolated people. Make connections with your local dentist.
We're back again on the 4th of March with a program for you about relationships between mental health and drug and alcohol use. We look forward to your company then. Thanks again to our studio panel, our godlike GP, Olga. Thanks, Olgs. And Ian and Mark, thank you for being with us tonight.
It's a pleasure.
Thank you.
That's it from us. Thanks to all who've been involved in the program. Most of all, thanks to you for taking the time to join us. Good night to you.